Hopefully, during these 20 minutes, we will discuss on the role of the anti-HLA antibodies in transplant outcome, focusing on the different insights that came from a joint effort between EBMT and the ASTCT. This is my disclosure. So as we can see, the number of patients transplanted for different hematological disease is constantly increasing during the year, and these are data from the recent export from the EBMT registry. And giving this constant increase is also related to more common use of mismatched transplant, namely those marked in the red plot performed using an haploidentical donor as the main donor. This is still growing, and actually since the early 2010, due to the implementation of the GVHD prophylaxis with the use of post-transplant cyclophosphamide. So a different approach than that was discussed previously by our previous speaker, Dr. Malar, so non-T-cell depleted and using post-transplant cyclophosphamide. Of course, in the setting of mismatched transplant, some of the main complications, such as the risk of graft failure, can increase, and it is important to proceed with a careful workup to reduce the risk. Graft failure is one of the major complications also associated with reduced survival probability. One of the most common recognized causes of immunological rejection after mismatched transplant is the presence of donor-specific antibodies, which are in particular antibodies versus the HLA in the HLA loci. The increased capability to detect DSA and to allow to distinguish their clinical significance and perform a process of desensitization for patients with DSA in case of no further donor are available. And these allow to reduce the incidence of DSA-induced graft failure and improve the overall transplant outcome. So here is a recent analysis reporting how the incidence of DSA across the different types of transplant change, of course, in the setting of more mismatched, ranging from 3 to 30% in the reported experience after haploidentical transplant versus 1 to 10% in case of unrelated donor, especially when the mismatched unrelated donor is performed. And this is also a very well-known factor associated with graft failure in case of cord blood transplantation. So which are the main factors associated with the risk of developing a DSA? There is the exposure and the multiple blood transfusion, which is very common in patients receiving transplant for hematological malignancies. The older age, the multiparity, and a gender distribution higher in case of female donor. So since the beginning of mismatched transplant, the impact of DSA on graft failure has been reported as a factor associated with graft failure and overall reduced transplant outcome. Here we can see a report from the CIBMTR in more than 500 patients receiving an unrelated donor, in which the cumulative incidence of neutrophil engraftment was significantly lower for those patients experiencing DSA before transplantation. And this has also been reported in the setting of haploidentical donor transplant, namely those with T-cell depletion or non-T-cell depletion, as well in the setting of cord blood transplantation. So not only a higher incidence of graft failure, but also a lower probability of overall survival and progression-free survival. So these make the things and the need of understanding how this could be considered in the preparation and the workup of patients before transplantation. This is a recent meta-analysis reporting how overall the results are very homogeneous, showing how both the graft failure and the reduced overall survival are consistent across the different studies in and also registry studies from the Japanese and the European and also the US. So it is a clear important risk factor associated with the transplant outcomes, and this made a clear need in trying to discuss and consider how to develop some recommendation for the test and the treatment of patients with DSA. So this was a very important joint effort that has been published last year in the Transplantation and Cellular Therapy Journal, reporting all the different factors associated with the incidence of DSA and how to proceed with the testing and the treatment in case of patients. So it is now clear that the anti-HLA antibody testing should be part of the pre-transplant workup at least 1 month before the starting of conditioning regimen in the patients receiving unrelated and mismatched transplant. It is more and more recommended to extend the testing for DSA also in cases of related, just to look at the presence of anti-HLA, not DSA, and to note also in that case the possible alloreactivity of those antibodies. A donor without corresponding HLA is preferred for a recipient with anti-HLA antibodies, of course, in addition to the other donor-related factor. And we will discuss also about some possible strategy for the DSA desensitization therapy to foster the neutrophil engraftment and improve survival for a recipient with DSA when a suitable alternative donor is not available. So there are several different techniques used for detecting anti-HLA antibodies. One common is the cell-based assay, which require viable lymphocytes, but is associated with low specificity and sensitivity. And among the cell-based assay, both the flow cytometry cross-match and the complement-dependent cytotoxicity are two useful method used for detecting the antibodies. And the solid phase immunoassay is the actual recommended methods for screening and anti-HLA antibody verification. It is based on a semi-quantitative method which identify the antibodies with HLA allele specificity, and it could be used for the test before the donor selection. The timing to get the results is approximately 1 week, between 2 and 5 days, and the results are provided in MFI, mean fluorescent intensity, which means the strength of the antibodies to provide the effect. And this is commonly a recommended method, and it can be used both for screening and for anti-HLA antibody identification, and it is used more commonly in the routine practice, also including some specific HLA locus such as the DQ and DP for the testing. Another important test which has been more and more used and is becoming frequent in the analysis is the complement binding immunoassay, which is able to identify the anti-HLA antibodies that can activate the classic complement pathway. And it is nowadays reported how the C1q positive test is associated with a risk of graft failure, is predictive of graft failure, and therefore this test could be incorporated in the workup. Importantly, it can be also performed when patients at still a high level of MFI, which are important for proceeding with the desensitization and then the monitoring of the anti-HLA after transplantation. So what about the level of DSA and its clinical impact? Of course, there is still high heterogeneity in how the different centers can interpret and consider. In any case, it is really, really important to consider that low MFI level, such as those less than 2,000 for haploidentical and unrelated and 1,000 for cord, it is more recommended to proceed with a further test before starting on conditioning regimen, and then monitor the increase of the DSA level eventually. For those having a threshold higher than 2,000 of MFI or 1,000 in case of cord, the desensitization is required, while for those patients in which the level of DSA is much higher, it is recommended to proceed with an alternative donor or other investigational treatment. So it is among the different risk factor, a donor without corresponding HLA is still preferred in case of a recipient with anti-HLA antibodies. And this is important also to consider and to put your patients in the more safe way for achieving engraftment, and then proceed with reducing the risk also of secondary graft failure. Repeated DSA testing is important also for before the start of conditioning regimen for those patients who have a level of MFI which is not so critical for the impact on the graft outcome. And again, the testing for the complement binding immunoassay, it is very well predictive of the risk of graft failure, and it is consistent with the level of MFI. So it is easy to proceed with the C1q testing before and after desensitization in order to follow and to have a double check of the level of MFI in your patient. But when a second donor, it is not possible to be found, or also because you need to perform your transplant very urgent, it is another important possibility and an important approach is to proceed with the DSA desensitization therapy, which is required to promote the engraftment and may ultimately improve the survival for recipient with DSA when a suitable alternative donor is not available. So of course we need to work up and to test if a possible alternative donor is available, but in the case when it is not the case, there are several different approaches to proceed with the desensitization. And the method could be, of course, considered according to the standard practice of your center, or also a different combination in case of high level of MFI. One possible is the physical reduction of the circulating antibodies using plasmapheresis or immunoabsorption, or the regulation of the B cell content and the antibody production using the proteasome inhibitor or rituximab, the blocking of the complement cascade, and also the use of irradiated blood product in order to block the DSA with other donor-derived antigen. As well, the depleting of the content, also using the IgIV in high dose. So here is again I recommend to refer to the recent publication on TCT, which I mentioned, to find all the different indication for the references. And here is a very detailed table reporting the different methods of combination using, for instance, the B cell removing in combination with additional treatment such as IgIV or plasmapheresis. And of course, it is important to consider that the protocol could vary across the center, but it is very important to have your own protocol to start promptly before the starting of conditioning regimen, in order to be also able to evaluate again the level of DSA before proceeding with the transplant. So one other approach is the multimodality desensitization approaches, which has been reported by colleagues from US, and Stefan Surea is the first author, showing a combination of the physical remotion, so the plasmapheresis, and in alternance with the anti-CD20 and the high-dose IgIV, in order to reduce and to reduce the level of antibodies, the burden of antibodies, and then reduce the risk of graft failure. So this could be also a multimodality approach in case you want to combine the different techniques, and especially for patients with a low level of MFI, of course, low intensity protocol such as the single use of rituximab plus IVIG could be considered in case of some contraindication to the different plasmapheresis. So these this is important to plan and have your own protocol ready to be started in case of patients with anti-HLA and no possible rescue donor. One important recommendation is also to monitor after the desensitization protocol, and then consider also a further test at day 0 and at 7 days after transplantation in order to start, in case of presence of residual DSA level, start also with sequential IgIV or other monitoring for the possible risk of graft failure. So not only your desensitization strategy, but then the monitoring of the DSA at day 0 and day 7 to eventually further prevent the risk of graft failure. Most commonly, the DSA are monitored at 1 day before transplantation, but several different data confirm the importance also of having a day 7 evaluation in order to implement further desensitization strategy in patients with persistently high DSA or increasing DSA level after stem cell infusion. So as future direction, it is important to consider that we need common laboratory methods to detect anti-HLA antibodies and also having an optimal turnaround to get prompt responses and good timely feedback. And higher level of evidence with prospective multicenter studies are needed for standardized the desensitization protocol, and also try to combine the different possible techniques available in case of individuals DSA level in order to tailor your strategy for your specific patients. And with that, I conclude thanking all the patients and family, all my colleagues at the San Raffaele Hospital in Milano, and all the members of the CTI-WP in EBMT. And we welcome all of you for a possible collaboration and studies analyzing the role of the immunogenetics in transplant outcome. Thank you.